Thank you, Doctora, for such a nice introduction, and thank you all for coming today. As we all know, plasma cell myeloma is such a complex disease, and within the next 25 minutes, I'll try to cover three main key points. We'll go over some rationale for the update criteria. There is not much update from the International Myeloma Working Group since 2014, so this session will be mostly a review on the previous diagnostic criteria. Also, we'll touch on risk stratification for myeloma and its precursor lesions, and then we move to MRD testing and its application in multiple myeloma. So, to start with a timeline, the most recent update was issued by the International Myeloma Working Group, which is almost the largest group of researchers interested in multiple myeloma, to include more than about 300 myeloma experts, actually from 40 different countries. So they issued their diagnostic criteria in 2014, and the WHO actually take their diagnostic criteria exactly as is and list it as the WHO diagnostic criteria. This was followed by a 2015 revision in the International Staging System, and they issued the revised International Staging System in 2015, where they added the LDH and some cytogenetics marker to the original staging system. Also, some slide in this presentation would include some information from the most recent WHO 5th edition 2022. So without further ado, just to review plasma cell myeloma. It's kind of unique in its presentation, where it presents with bone marrow plasmacytosis, osteolytic bone lesions, and monoclonal gammopathy, or M protein. It's not a very common disease. It accounts for 1% of all cancers, and this is actually coming from the Saudi Cancer Registry in 2015, where it accounts for 5% of hematolymphoid malignancies in the kingdom. It has a rate of about 10 to 20%, depending on the reference you read, for the international or the global rate of myeloma compared to hematolymphoid malignancies. So the traditional way of diagnosing multiple myeloma, as we all know, it has two parts, a laboratory finding and some clinical findings. So the lab part, we need to provide evidence of clonal plasma cells, more than 10% in the bone marrow, and the clinical part or finding of the clinical findings, usually shortened in a mnemonic called CRAB or CRAB, the famous CRAB criteria. But this was changed by the 2014 addition of a slim CRAB criteria. And the International Myeloma Foundation added 3 more points, or what is so-called biomarkers of malignancy. As we are all familiar with the end organ damage, or the evidence of end organ damage by the CRAB criteria, the hypercalcemia, the renal impairment, the anemia, and the bone lesions. The 3 more criteria do not fit necessarily as an end organ damage or evidence of end organ damage. So they are called biomarkers of malignancy. But both the evidence of end organ damage and the biomarkers of malignancy combined together are called myeloma defining events. And what they did basically in 2014 to come up with this criteria is they actually looked back at a large group of patients, asymptomatic patients, to identify who is going into multiple myeloma earlier or faster. And here I show you an excerpt coming directly from the WHO classification of hematolymphoid malignancies. And notice the first 3 points are actually the biomarkers of malignancy added in 2014, and the bottom 4 are the regular myeloma defining events, or the evidence of end organ damage, the anemia, hypercalcemia, and lytic bone lesions. As we are all familiar, those criteria are well defined by specific cutoff points for calcium, creatinine, and hemoglobin, for example. And just like we have corrected serum calcium for patients with renal failure, now since they added the free light chain as one of the criteria of over 100, Some of those patients actually would present with an underlying kidney disease, and the I-STOP multiple myeloma study group or prospective study, actually they came up with a reference range for serum-free light chain to adjust for the renal disease or the underlying renal disease. So they came up with 3 different reference ranges for serum-free light chain based on the estimated GFR in 3 different categories. I-STOP multiple myeloma is one of the largest prospective studies in asymptomatic multiple myeloma. It's a screening study where they included many patients, about 80,000 people actually in the screening program, trying to identify the rate of AMGUS and the value of doing a screening program for AMGUS in terms of myeloma. So here I provide you with a visual. If you look at the top triangle, let's consider that as a bone marrow cellularity. The red triangle is the portion of plasma cells within that bone marrow. And then we have set of couple of points, cutoff points. So we have 10% plasma cells and 60% plasma cells. And at the bottom, the different disease categories. This actually helps us in identifying multiple myeloma as it sits on a disease spectrum. It's usually preceded, or it's always actually preceded by an asymptomatic stage of M protein called AMGUS, or monoclonal gammopathy of undetermined significance, and asymptomatic multiple myeloma or smoldering multiple myeloma. So if we consider a patient with less than 3 gram M protein, and this patient who is asymptomatic, doesn't have any of the CRAB or the slim CRAB criteria, he or she would need a bone marrow examination to complete the workup. And if we find less than 10% clonal plasma cell within that bone marrow, this patient will be termed AMGUS, or monoclonal gammopathy of undetermined significance. Those patients have a well-defined risk of progression into multiple myeloma, and it's estimated at 1% per year. If the same patient has more than 10% plasma cells, those would be termed smoldering multiple myeloma, and they have a higher risk of progression to multiple myeloma of 10%. So you see, basically we're trying to identify who is going into multiple myeloma, who is going to show symptoms earlier. And the whole idea of adding the myeloma defining events or the biomarkers of malignancy, the finding of more than 60% plasma cells in the bone marrow, more than 100 serum-free light chain, and more than 1 bone lesion on MRI or a very high sensitive radiology technique. What they found is basically patients or individuals with any of these features, they have a greater risk of going into multiple myeloma within the next 2 years. The risk is estimated at about 80%, and this is coming from multiple studies that are actually independent. So basically, why wait for those patients to call them myeloma and to have them eligible for treatment until they actually have evidence of end organ damage? So probably treating them earlier, being more proactive in the diagnostic criteria, would provide them with a longer overall survival and progression-free survival. So what happens is basically we kind of extending from one disease to something like this, where we have multiple myeloma with 3 different risk categories, and then the precursors with also different risk categories. I'd like to mention that myeloma risk grouping or risk stratification is based on who is the patient is going to relapse faster, or who are those patients who are at greater risk of relapse. While the precursor lesion, we're trying to identify who is the patient going to show symptoms or showing full-blown disease or multiple myeloma. This is currently based on many clinical and some laboratory and genetic findings, but hopefully this would change in the future, where we'd have a more solid and hopefully molecular-based classification system. So here I show you a table from the WHO hematolymphoid malignancy. And for risk stratification, we can see the ISS, or the International Staging System. It is the most reliable risk stratification system that we have, and it's based on beta-2 microglobulin and albumin. But at the bottom, as you can see, the revised International Staging System was issued in 2015. It's basically the same, but they have added 2 more independent prognostic factors, the LDH and the cytogenetic findings. There are multiple cytogenetic findings or translocations are well defined to be associated with high-risk multiple myeloma. Those are defined by the International Myeloma Working Group, and they are included in the risk stratification of the International Staging System, which made the staging system actually much better in discerning those patients who are at higher risk of relapse. In the middle, we have the International Myeloma Working Group staging system, which is basically the same, and they share so many of those translocations. In fact, the 414 is shared, chromosome 17, which carries the P53, is also shared, but they are different in one finding. So the Myeloma Foundation is interested more in chromosome 1 aberrations. They want to exclude that for patients to be called low risk. And the revised International Staging System, they are interested in 1416 to be excluded for patients to be called low risk. And the means of testing, it is recommended to do FISH. FISH is the gold standard for those patients, as it shows more abnormalities. Conventional cytogenetics kind of is disappointing, where it shows only about 30% of those plasma cell myeloma would actually show abnormality based on cytogenetics, so conventional cytogenetics alone. So as a result of those, there are baseline genetic information that should be acquired on each and every newly diagnosed multiple myeloma. The minimum FISH panel include deletion 17, 414, and 1416. This is by the International Myeloma Working Group, but they also advise for a more comprehensive panel to include chromosome 1 and diploidy analysis, or diploidy category. So aside from the conventional cytogenetics or the translocations, the well-known translocations, the M-SMART staging system, based in Mayo Clinic myeloma interested group of researchers, they actually came up with the M-SMART. A new concept that has been added to their staging system is the presence of double hit. A double hit lymphoma is a well-known concept where we have aberration in BCL2 and c-MYC, for example, and diffuse large B-cell lymphoma kind of infers a more aggressive behavior. The same concept, or a similar concept here in multiple myeloma, where they found the presence of double hit, meaning having 2 of the high-risk, well-defined high-risk cytogenetics abnormalities, having 2 of them in the same patient actually confers, or it's considered as an independent prognostic factor on its own. And they found the overall survival of patients with double hit to have about 6 months, while with no risk is about 57 months of overall survival. So the risk stratification for multiple myeloma comes into play as for the disease, the treatment choice, basically. Once we diagnose those patients with multiple myeloma, those patients would be for a lifelong treatment. It's well known that multiple myeloma is not a curable disease, and they need follow-up and disease monitoring very effectively. But the risk stratification for multiple myeloma as a patient would kind of allow or dictate the type of treatment they are getting. Basically, multiple myeloma would be treated initially at least at the same, basically based on their age and other criteria. But for high-risk patients, they would show more benefits if they go with the high-dose chemotherapy with tandem auto transplant or stem cell rescue. So risk stratification plays a major role in treatment for multiple myeloma, but risk stratification for precursor lesions plays a major role in the frequency of follow-up and trying to identify those patients and have a good follow-up plan for those patients. So this is a table from the WHO also showing the risk stratification of IMWG patients. Those are the asymptomatic patients with hanging M protein in their serum. The risk stratification is based on a few laboratory tests. Basically, the value of M protein, the IG subtype, and the serum free light chain as well. And notice the absolute risk of progression at 20 years can go from 5% all the way up to 60%. Oops.
3 minutes, Dr.
Yeah, 5% all the way to 60% if it is the highest risk. Thank you. Also, for predicting the need for bone marrow, this is something I found while actually reading on the topic of risk stratification for IMWGs. In the same group of iStop-MM based in Iceland, they came up with this experimental, or still it's actually under review, but you plug in some numbers and it kind of tells you the likelihood of finding more than 10% plasma cells in the marrow. Basically, if you have a patient with an hanging M protein, I believe once this is actually reviewed and published, I believe this would be a good tool to estimate the risk of smoldering multiple myeloma in IMWGs patients. So IMWGs is also subtyped based on the IG subtype. Non-IgM IMWGs is the most common one, and the risk of progression is usually 1 per year across different studies from different on the globe. The risk of progression going into multiple myeloma, amyloidosis, and plasmacytoma. Light chain IMWGs has a lower risk of 0.3%, and IgM IMWGs, which is associated with lymphoplasmacytic lymphoma and Waldenström microglobulinemia, has the highest risk of 1.5. So accordingly, disease monitoring for those patients based on the risk stratification and their type, they usually have different follow-up plan, either biannual every 2 years or every year, once a year, basically, for high risk. For smoldering multiple myeloma, as we know, it's very similar to IMWGs, but you have a higher portion of M protein and higher percentage of plasma cells, but it's a must that you don't have any evidence of end organ damage or none of the myeloma-defining events. The risk of progression to plasma cell myeloma kind of goes down with time. The first 5 years is 10%. The following 5 years is about 3%, and then goes back to IMWGs rate, where it's only 1% per year risk of developing multiple myeloma. So they are called high risk, also classified into high risk if they have high protein, more than 30 grams, and then they have higher percentage of plasma cells also, 50 to 60% plasma cells. They are approaching to the multiple myeloma level. If they have any circulating plasma cells, if they have the serum free light chain more than 8, and if there is evidence of progressive M protein. And here is the monitoring of this patient. Actually, they would need a follow-up M protein level 2 to 3 months right after the diagnosis. And this is how you identify the presence of progressive increase in the M protein. While the risk stratification for precursor lesion, IMWGs, and smoldering was based on clinical findings and laboratory findings, Dana-Farber in 2020 tried to incorporate NGS findings into risk stratification for smoldering multiple myeloma. They basically studied the DNA repair pathway, the MAPK pathway, and the MYC aberrations. And based on those, they classified patients into higher risk of progression to myeloma within 2 years or low risk. Also, I would like to mention, once we treat those patients, and we need to monitor those patients very closely for relapse. For minimal residual disease testing, there are basically 2 common methodologies. Both are FDA approved. There is the NGS, or the next generation sequencing, and the NGF, or next generation flow cytometry. Both are based on a bone marrow biopsy, which is invasive. Both are excellent in identifying very low percentage of malignant plasma cells. But the application of those testing are still limited to clinical trials, as clinical guidelines are not available as for well-established for like PALL or other minimal residual disease testing. So the flow cytometry part, basically the FDA approved one is developed by Euroflow, and it's actually a global standard for MRD, where they compare your patient sample to a large set of data stored within the Euroflow database. But other group of researchers actually try to imitate the same panel devised by Euroflow, trying to decrease the cost basically. And they showed promising results. So more of this, I guess, is coming in the market. Also, something new in terms of minimal residual disease, especially in multiple myeloma, as we just mentioned, the NGS and NGF are based on a bone marrow invasive technique, a bone marrow biopsy, but a newer methodology, which is the mass spectrophotometry use for the immunoglobulin, actually based off serum protein, trying to identify minimal residual disease. And it's actually a very basic methodology where they actually study the mass of the peptide change, very specific, on diagnosed initially and then followed up by mass spectrophotometry. Just 2 words on plasma cell leukemia. They have decreased the diagnosis or diagnostic criteria for plasma cell leukemia from 20% to 5%. And I just like to mention that this diagnosis is, you can make this diagnosis only in patients who had established symptomatic plasma cell myeloma. The identification plasma cells in the peripheral blood is very difficult by morphology and also by flow cytometry, as we know with plasma cell inherit problem in flow cytometry. Last but not least, this is the newest addition in WHO. So just like we have MGUS, monoclonal gammopathy of undetermined significance, we have MIGRUS, which is monoclonal gammopathy of renal significance. And for those patients, you need evidence that you need actually to exclude any evidence of end organ damage. You need a biopsy-proven kidney biopsy proving that you have a monoclonal immunoglobulin deposition and kidney damage, but you don't have any evidence of that monoclonal antibody causing damage anywhere else in the body. And this is how you make a diagnosis of MIGRUS. It's a clinical pathologic diagnosis. With that, I conclude, and thank you so much for listening.